There we go.
Okay. Well, it is 6 o'clock. My goodness. Well,
Yes,
let's
it
get
is.
started. Good evening, everyone. My name is Chef Cheryl Tate. I am the Health and Wellness Director of the LA South Chamber of Commerce. I am speaking through Dexter McLeod, but I am Cheryl Tate, and we are here to bring you the health literacy, a key to increasing patient success. We have an awesome group of ladies here talking today. One, we have Sister Anissa Muhamed and Sister Shemika Mitchell. Will talk. Both are healthcare providers. They are awesome people. They are going to talk about health literacy, a key to increasing patient success. We want to thank you so much for being here today. Again, this is the LA South Chamber of Commerce, and this is our health and wellness team presenting this information this evening. I'm going to go page down. So this is about our presenters. Would you like for me to read this, Miss Anissa, or would you like to read it?
I would like for you to read it.
Okay,
And
very good. Thank you. About our presenters this evening, we have Sister Anissa Muhamed, who has a master's in public health and a master's in science, if I am correct.
Yes, ma'am.
She's a graduate of Charles R. Drew University of Medicine and Science, a co-vice chair of the Alumni Association. 20 plus years direct and indirect care for patients with
diabetes, hypertension, COPD, dementia, stroke, and Alzheimer's.
See, thank you. You do a much better job than I do. A QI team leader, improved workflow and operational processes, and PCMH, received 5 achievement awards, hosted health-related community-based workshops, seminars on topics, including cancer, diabetes, how to eat to live, diabetes, whatever that is.
That's domestic violence and hypertension.
Don't let me mess this up, my God. Okay, subject matter expert in health literacy. We'll just leave it right there. How's that? 80% success rate with CHW, which is a part of the LA County Department of Health Services. She is a co-author of the #1 best-selling book, Repair of the Black Family Anthology. Thank you so much, Sister Anissa, for your work and for your education. Shemika Mitchell, I unfortunately don't have her information, so I will ask that Miss Shemika please give us a curriculum vitae.
Hello, everyone. I'm Shemika Carter-Mitchell, between Carter and Mitchell. I am a board certified adult and gerontology nurse practitioner. I have about 25 plus years experience as a nurse, working in varied nursing specialties. My experience kind of guides the pathway that I choose for my patients under my care. I'm the owner of True Care Telehealth and House Calls Practice. We are a telehealth and house cost practice. We also have a clinic here in Diamond Bar, California, where we are a wellness practice ran and operated by nurse practitioner and nurses. I am a former director of nursing services at skilled nursing facilities for about 9.5 years. I almost made the 10-year mark, but I missed it. I graduated from MP school, so I got 9.5 years. I'm an expert adult care practitioner, master trained nurse, master trained nurse with the authority to assess patients and diagnose their sickness, order and interpret labs. I create and manage care plans. I consider myself a care plan expert. A care plan expert is just a person that goes in and look at a human being from a holistic view, mind, body, and soul, and create a plan so that person can get on the journey to health and improve the quality of their life. I use my expertise to be an extension in the community. I'm a liaison between the physician and the patient, so I kind of sit in the middle. My commitment to care leads to better care outcomes and higher satisfaction for both the patient and for our practice. And then we provide a scope of care that you don't generally see in the physician office. So that's me, Shemika Carter-Mitchell. Thank you for having me.
That is awesome, awesome work experience. Thank you, ladies. So we're in for a treat today because we've got two masters at bat here. So I am the person that does the PowerPoint, so forgive me. And ladies, when you're ready to go to the next page, just let me know. So start our first page. So thank you so much.
Thank you, Sister Cheryl. And I also want to take a moment out to thank the Los Angeles South Chamber of Commerce for letting us on their platform to be able to provide this service to our communities. The Chamber and its members recognizes that there are so many inequities in our community, and one of our jobs on this health and wellness team is to kind of close that gap. And as we discuss health literacy, we're going to define what health literacy is. And technically, according to the CDC and other governmental entities, health literacy is defined as a degree to which individuals have the capacity to obtain, process, and understand basic health information to make appropriate decisions. What that means in layman's terms is that the patient will take the information given to them by the doctor and act accordingly so that they can receive the best outcome in their health. Next slide, please. There is a vast difference between literacy or functional literacy and health literacy. Functional literacy is just the basics about a person's ability to read, or should I say call out words. Health literacy focuses on the individuals, not only their ability to read, but the capability to carry out tasks given to them by their doctor or their nurse. Next slide, please. In the United States is the most complicated healthcare system in the world. And as of May 25th, when this slide deck was created, there were over 336 million people living in the United States. 78% of that total population are adults that are at 18 years old or older. In 2019, adult inpatient stays were associated with comorbidities, and comorbidities is having more than one chronic disease at the same time. Okay, approximately 80 million adults in the US have a limited or low health literacy, and research has indicated countless times that low health literacy contributes to poor health outcomes and hospital readmissions. Sister Shemika, would you like to add to that?
Yeah, you're right. The low health literacy, meaning in the United States, it's documented that most citizens have a 6th grade education. So if you have a 6th grade education, and the literature that's written for the doctor's offices, those brochures and all that, it's written at an 8th grade education. So if the vast majority of the people only have a 5th to 6th grade education, but the literature is written at an 8th grade education, it's like speaking a foreign language to them. And we see it every day in the care. So I 100% agree with this slide.
Thank you so much. Next slide, please.
Yes, 1 second, please. There we go.
Sister
Okay.
Cheryl is going to start a video. It's about almost 5 minutes long, and it was created by the American Medical Association Foundation. It is about patients and their health literacy.
I was sick a lot. Because I probably missed something and didn't realize that I was in the hospital a lot. When they did give me medicine, they didn't take
We
away.
can't really hear it.
Can you turn it up a little, Cheryl?
Sure.
Can read this. Well, I think give it to me, so it's okay.
Cheryl, would you be so kind, because this is really very, very important to this presentation. Can you pause yours and allow me to share the screen? And I can run it,
No.
and I can really literally run it from mine. If
Okay,
you all
of
would just
course.
bear with us, please.
Of
Thank
course. Mhm. Okay, Anissa.
Okay,
Oh, gosh. Okay, hold on.
it's
And
okay.
I have made you. Wait, hold on. Okay, you started screen sharing.
Yeah,
Oh, gosh. Okay,
Click.
okay, hold on for 1 second. Gosh.
But you know, you have high blood pressure. Hypertension doesn't mean the same. So if I ask you if you have hypertension, you're going to just be jumping around the chairs.
you okay, Cheryl?
I don't know how to stop it.
I was sick a lot because I probably
I don't
missed.
know.
Can you all hear it?
Realize that, I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them and I didn't have the nerve to ask them
I don't know how to stop
the right
it.
way of doing it. I just didn't have the nerve.
Okay.
I didn't want anyone to know I couldn't read.
Are you all able to hear the other video?
We can hear this one. We weren't able to hear the one that had a picture, but we can hear the audio even though there's no video.
Really?
Yeah, because the other one was blurred. I couldn't hear anything that the lady was saying, but I'm hearing her say that she couldn't read and or understand the literature.
Okay,
Cheryl, can you stop? Are you still able to, are you able to stop yours?
okay, hold on for 1 second, please.
Okay, yes, ma'am. Thank you all so much for your patience. Pardon us while we make progress. Thank
Okay.
you.
Thank you. Okay, so I have given you the screen, and so now you can try it. Try it now.
Because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess he, doctor, give it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them? Motrin or Tylenol, mostly Motrin, because that's what my doctor recommended. How old is your daughter? She is 4. She's 4. Okay.
Can you guys hear this?
Give her the 4 to 5 tablespoons and a half.
One capsule.
That's right. One capsule.
One capsule. I don't know, that's twice daily.
Can you hear it, Cheryl?
So what?
Yes?
Okay.
I can hear it.
It's not only I tell you how to take it, it said take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension and I've been taking care of that for a long time.
Hyper.
Like you're hyper? What does being hyper mean to you?
Just where you can't be still, you always gotta be doing something.
Do you think I think you're hyper? You have hypertension?
I don't know, that's what I consider
Okay.
it being, you know.
But you know you have high blood pressure.
Uh-huh.
Okay, but hypertension doesn't mean the same to you.
Uh-huh.
So if I ask you if you have hypertension, you're gonna just think I think you're jumping around on a chair or something like that. Something different.
Being hyper, you know.
Okay. All right. Well, I haven't done a very good job teaching you about hypertension. Because I think you take that medicine for hypertension. And that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension to us, it's the same thing.
Same thing.
Yeah.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult to for me to take these pills because if they say one tablet twice daily, I don't know if the top can take one in the morning, one in the evening, or take one in the afternoon or one in the evening. So usually what I do is take 2 of them in the morning. And this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office and most people, if you realize, the first thing you're gonna have to do if that's your first visit is fill out a form. Your heart beat real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets, and I wasn't going to reveal my sense of stupidity. So I signed everywhere they told me to sign, never read it. And then a couple weeks later in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now I acted as normal as I could. Inside, my mouth fell open and I thought to myself, how could I be so stupid as to allow somebody to take part of my body and I didn't know it.
Okay, Cheryl, I'm gonna stop the sharing
Yes, ma'am.
so that you can go ahead and resume control over all of the yummy stuff.
Okay.
Thank you all so much for helping us and being with us during that brief time of technical difficulty. And so Shemika, would you like to chime in about what it is that you heard coming from those patients?
I heard what I often hear, which is a lot of confusion, and there's confusion, rightly so, because they don't understand what's being said, but because it's an adult, it tends to be like some of the patients said. It was embarrassing. Like, she signed those documents without even knowing that she's signing for them to literally take out her whole womanhood, take her uterus out. That's not the first time that has happened. And it's simply because the patients don't understand, and they don't have the wherewithal to say, what is this? What is this? The patient has to be the gatekeeper for their life. We are participants in that. The healthcare provider is a participant in that, but you yourself have to be the gatekeeper for your life. You never sign a document, especially at a doctor's office, and you don't know what you're signing. It's one thing to sign away your house. That's a material thing. You're going to sign away your uterus and fallopian tubes? No, so you have to say what's going on. The patient has to be the gatekeeper for their life.
Wow. I hope and pray that that has not happened to anyone that's listening to this, but in the field of healthcare, that is a reality where you have a lot of patients that don't understand what doctors are saying. It is not just necessarily because of their own low functional literacy skills. A lot of it has to do with the primary care provider, meaning that a provider should be able to pick up. There are cues where the doctor should be able, or the provider should be able to tell whether or not that patient can read or write. And they should always speak in layman's terms when they're speaking with their patients. According to the Institute of Medicine's, healthcare practitioners really have to understand where their patients are coming from in order to assist them as well. Meaning they should know the beliefs, the values, the culture, the mores, and the traditions that influence healthcare. And it's not necessarily individually, but also perhaps the culture of a particular ethnicity or a particular group of people or the communities that they are serving, which would be very, very helpful.
Okay, Sister Anissa, you are a host, so you're doing your
Okay,
PowerPoint. Thank you so much.
You're more than welcome. So Shemika and I are going to just discuss this issue about keys to patient success.
Awesome.
Okay. As a patient, I want to share with Shemika, my provider, that I want to be heard. I want to be talked with and not talked at. What does that mean? When you come in an exam room where I am, don't just look at your screen. Can you give me some eye contact, please? Can you say hello to me? Ask me how I'm doing. Ask me what my health goals are or what's preventing me from being able to achieve a manageable A1C, for example, especially if I've seen or have been assigned to the same provider for 5-10 years and my health status is not improving. It doesn't necessarily mean that I don't want to comply. It could mean that I'm having difficulty understanding the provider and what he's saying. I don't read well enough to understand the instructions on the label on my prescription medications and different things like that. And most importantly, I want to be treated like a person. I'm not my medical condition. I'm an individual. I'm a human person. Does that make sense, Shemika?
That makes perfect sense. That makes perfect sense.
Is
So,
that how, I mean, I look at it as even doctors and nurse care practitioners, everybody is a patient of somebody somewhere. So is that how would you want to be treated if you were seeing your own primary care doctor, Shemika?
So that question can be answered many different ways, but I'm going to, for the sake of this conversation, I'm going to answer it this way. It's all dependent, right? It's all dependent on the individual person and what they are in the physician's office for. And we'll talk about that when we get to the next slide. Okay. But a lot of times, as a provider, what goes through their mind is, I need to get in here, I need to see this patient, address this issue, and I need to get to the next patient. We do take cultural competency and cultural competency courses where we need to learn the person and learn different cultures. But if the patient is jumping from provider to provider, you're not really giving anyone a chance to get to know you. That's why getting a provider is somewhat like fishing. You get a provider, you go to them for a couple of visits. If it doesn't work, if this is someone that you don't agree with, hey, there's no binding contracts. You throw that fish back in and you fish for another one, the one that's right for you, because all providers are not going to be the same. And unfortunately, here in California, we're a melting pot. So we have all different types of cultures, and we have a lot of medical doctors that are from overseas, India and different, and you know, Asia, and their cultures are different, and they bring that here. And the patients tend to get offended thinking that they're ignoring them, but they're really not. It's just how they were raised, especially in the Indian cultures with Indian doctors. They don't really look you dead in the face, the Asians neither. And you think they're ignoring you, they're listening, but you know, that's how they communicate. So if that doesn't work for, let's say, an African-American patient, then it's the patient's responsibility to put that doctor back and get one that works for them, and keep moving until you find someone that fit you. You can't stop. So yeah, it takes work on the patient's end. I would want to be treated with respect and dignity. My PCP is an African-American woman because I refuse to deal with exactly what you just said.
You know, and it sounds strange. And I know that there has been times where I had to go to see a provider, or even going to, as a matter of fact, I had a visit in an emergency room for something that was going on with me that nobody could understand. And it had been happening, right? It came into, it manifested during COVID, and it was never addressed. So by the time I got to the emergency room, the nurse practitioner came in. Not one time did she look at me. She went to the computer. I see that you're here for blah, blah, blah. And I kept saying, excuse me, because I wanted her to see what was happening to my skin. And she still kept jotting things down and typing in the computer. And I had to literally say, will you look at me? And I had to say it with force and power and authority. And that's when she looked at me. And she came closer. And when she saw my face and she saw my skin, she said, oh my God, I'm sorry. And so my experience personally, and being in rooms with patients that were on my caseload, there had been many times where the patient was trying to tell the doctor something related to what they were actually in the office for. And the doctors did not, in our opinion, did not really fully, as you said, they were probably thinking about the other patient or the other 3 patients they had right behind this one, but they still at the same time cannot ignore the person that's in that room with them. And you know, that whole situation with me, it frustrated me. And she looked at me very puzzled, and I just let her know, because I knew what would help. I'm going to say fix it. And I told her what it is. Okay, so this is what I need from you. And I told her that I would like, if it's okay with you, if you think this is a good treatment regimen, can I get some prednisone that's titrated over at least 10 to 14 days? I need some sort of hydrocortisone type ointment for this, because I have, and you can probably still see it, it's gotten better, the hyperpigmentation that was on my skin. I mean, my face was so swollen I could barely open my eyes. And I had been to quite a few UCCs and in emergency rooms, and nobody addressed what my needs were. And I know that that's not the rule. In a matter of speaking, that's an exception. I'm not saying that everyone is like that, but I know that those types of experiences really messes with the head of some patients, and it makes them not want to come see a provider. Now, what if I did not know anything about medicine, or really didn't pay attention to my body and my needs? Where would that have left me as a patient? And so ever since that time, I have really, really been going very, very hard on making sure that people understand the protocols of the healthcare system, and they have to stay with their protocols. But most importantly, it is the patient's responsibility to advocate for themselves. I'm going to go to the next slide, where we're going to talk to Ms. Carter-Mitchell about what a provider's position is in a healthcare setting.
So I want you guys to understand first that people don't go to medical school to mistreat people, or people don't get into nursing to mistreat people. Our system is broken. It's not irretrievably broken because it can be fixed, but it's going to take an all hands on deck approach. I have to say that a million times over. What needs to happen is everyone has to understand how this system works. Okay. So when you go to the doctor, if you're going to the doctor because something is wrong with you, if you're going to the doctor, the nurse practitioner, because something is wrong with you, you have a urinary tract infection, you have an upper respiratory infection, you have an ear infection, you have an eye infection, that's called an episode, an episodic visit. The doctor only gets 20 to 30 minutes for an episodic visit. You can't talk about nothing else except for what you set that appointment for. It's 20 to 30 minutes. They have to, within that 20 to 30 minutes, they have to examine you, they have to document, they have to do any referrals that's needed, and that's all they had. They have to treat you, give you any type of medication that's needed to help get whatever's going on under control. That's 20 to 30 minutes. You can't go in, you can't make an appointment because you have an upper respiratory infection or you have the flu, and then you get in there and you say, well, my leg has been hurting and this has been, they don't have, that's not what that's about. So that's the episodic visit. The follow-up visit is the visit that you go to after that episode. So they'll tell you to come back in 2 weeks or come back in 3 weeks or come back in 6 weeks. That's the follow-up visit. When you go to that follow-up visit, you're only going for them to follow up on that concern, whatever that concern was. Any labs, to review any labs that they drew, to ask how did the antibiotic work, how long did the symptoms last, all of that. That's what the follow-up visit is for. That's 20 minutes, and they have to document within that time too. They have to educate you, explain things to you, and document. So it's really rushed. You probably get it in 5 to maybe 10 minutes with the doctor, and then after that, they out, because that's what it is. A physical exam is what I 100% advocate for. Anybody that's my Facebook friend know that I'm constantly saying you need to get those screenings done. You need to get in there at least yearly to get those labs done. When you go for a physical exam, that is a 1-hour exam. Every human being should have a full head to toe physical exam once a year, especially if you're over 40 years old. Once a year, you need to have your labs drawn. You need to have your history taken, family history, social history. Did you start smoking? Did you start drinking? Did you stop smoking? Did you stop drinking? Did you start it? All of that is taken during that time. And any referrals for any screenings that's needed. When you go to your physical exam, this is different. This is where you take your top 3 concerns, top 3 things that's been bothering you about yourself. You have a piece of paper and have these things written down. Top 3 concerns, all the medications you taken, any supplements you taken, and any pertinent information that has happened since your last visit. They have time during this time to go through those things with you and to address everything and to give you the referrals and to actively listen. They don't have time to do that in the emergency room. They don't have time to do that for an episode, an episodic visit. They don't have time to do that for a follow-up visit. And I think because the population, I know you guys don't know this. I know the population don't know the guidelines that we have. But that's what it is. And most people, when they go to the doctor for an episode or for a follow-up, they want to talk about other things. And the doctor's like, no, no, no. And now we're feeling like he or she is being rude, but it's the doctor's responsibility to explain to you, this is just for this episode. If you have something else going on, come back tomorrow or set another appointment. That's just how it is. That's how they get paid. That's the standard. An annual wellness visit is for adults, it's 45 to 60 minutes, and it's for adults, again, 40 and older. You should have an annual wellness visit. It's kind of like a physical, but the purpose is a little different. The purpose of an annual wellness exam is to find anything that's going on inside your body that we haven't picked up on. You haven't started having symptoms yet, but it's there. That's what that annual wellness exam is for. So you have labs drawn, you're reviewing labs, you're reviewing any diagnostic ultrasounds, CAT scans, You're reviewing your kidneys, pancreas, all of that stuff, your eyes, your ears, your throat, to see if you're having any symptoms of obstructive sleep apnea. That's what that wellness exam is for. That's another very important thing. So those are two things that you could do once a year, that annual physical and that wellness exam, to get all of your needs met. But and I didn't put any stats in here, but according to 2019, the CDC, only like 7% of the US population is doing annual wellness exams. 17% of that 3 billion people are taking advantage of the annual wellness exam. That's why I say the system is broken, but we could fix it if everybody had that little bit of health literacy. As a patient, it's important that the patients are able to communicate, process, and understand basic health information. Like we discussed earlier in the earlier slides, health literacy is very, very important. You got to know if you have high blood pressure, you need to know what medications you're taking. You need to know if your lower back has been, or your mid back has been hurting for the last month or so. Those are issues you need to take to you have written down, and you have the time it started, how bad it get, and you take that to your doctor. If they see that you're organized, I promise you, they're going to take care of your needs, because they feel like you know what's going on. And nobody, trust me, we don't want to end up in malpractice lawsuits. They're thinking about that, malpractice lawsuits and losing their license. So if they know that you know what's going on with you, they're going to take better care of you. That's why I say the patient has to be the gatekeeper of their own health. When you're visiting your primary care provider, here's some tips to help you get your needs met. Can we have the next slide, please?
Yes, ma'am.
For episodic visit, if you're going, you need to make sure you have the date the illness began. What are your symptoms? What makes them better? What makes your symptoms worse? How much discomfort are you in on a scale of 1 to 10? If you're going in for an episodic visit, remember, episodic visit is something that just comes on urinary tract infection, upper respiratory infection, ear, eye, toe. Those are episodes of something that's going on. Those are the things you need to have. For your follow-up visit, you need to be prepared to only talk about the results of the testing that was done during that episodic visit. You're going to follow up your blood work, your blood pressure diary, weights, if you're going for weight loss or obesity management, your glucose, if you're a diabetic and you're going for diabetes, you need to have a glucose log, monitor, diary, whatever you want to call it, where you're writing down your blood sugar every day, and only discuss that at the follow-up visit. Don't bring other things in, because 9 times out of 10, the provider is going to cut you off and make you feel, bad or whatever. I don't know. And then for your annual physical, make a list of concerns in the order of their importance, your top 3 concerns in the order of their importance. Write down all your medications, including vitamins and supplements, and note all health changes, anything that has changed in your body since your last visit, any significant family health concerns like cancer. Let's just say, hypothetically speaking, somebody's sister just got a diagnosis of breast cancer, or somebody's father or brother just got a diagnosis of lung cancer, or like my dad, some years ago, he got a diagnosis of a mass on his lungs. Those are things that you need to take to that physical exam, because talk to your doctor about, because those are things that they're going to test for. Those are x-rays they're going to do, because 9 times out of 10, there's a genetic disposition and you could possibly have it. So they're looking inside your body to make sure none of that is manifesting. Be prepared for your visit. Do not ramble on with the doctor. Be direct. Read from your list and follow up with all the referrals and the blood work that they give you. You got to follow up. You got to be your own gatekeeper, because we're a melting pot and nobody really care if you don't care about you. Honestly, I've had a doctor tell me she don't care about her health. She don't care about her health. Why should I? I literally had a doctor tell me that to my face. So that's real. If you don't care, if they see that you don't care, that you're not doing your part, they're not going to care neither. They're going to go to the next person that care. I don't know if I have another slide or if I'm done.
I think as far as slides are concerned, this is it. This is,
Okay.
we only did the 10 slides.
Okay.
But I know that there's a wealth of information and a lot of questions that popped in my head as I heard you speaking on slide number 9. And I know that you had said that that the system can be fixed. What if there were, give me 3 things that if you had the power to change or fix, what would those 3 things be?
The first thing I would do is put more doctors and nurse practitioners in place that are, with all due respect, that are American, that understand the cultures and the norms of the different people here, that could communicate with the people. That's the first thing I would do. The second thing I would do is make sure that all patients were assigned to a care manager, because a care manager is going to break down that health information and help you understand it, help the patient understand it. A care manager is going to help the patient navigate the system, navigate the healthcare system, and get their needs met. And then the third thing I would do is I would, especially for states like California, but countrywide, I would give nurse practitioners full authority, full practice authority, where they don't have to practice under a physician. Yes, I would.
Yes, ma'am. When you talked about a care manager, can you tell me what exactly do care managers do? Because I heard you mention about patient navigation. And I know that as a community health worker and a community health person, that's what my fields of endeavor are. I know that there are a lot of social determinants of disease that may or may not be addressed in the doctor's visit. And I know, for example, I would want to know, and I did learn with my patient caseload, what I did home visits. What is your home like? Are you in a chaotic or toxic environment all day, every day? Or, or does drama come up every now and then? What type of food do you eat? And I know that in the poor communities, especially Black and Latino communities, our communities are inundated with fast food restaurants. But I know that restaurants their business is just like medical care. It's a business, and businesses are open to make money. So I don't, they go where the real estate is available. They're going to go where the customers are. And I share with people that just because McDonald's is there 3 steps away from your house doesn't necessarily mean you have to go in it. The money that you're spending to feed your whole family, you can actually spend that on 2 meals, maybe 3, depending upon what it is that you buy. And I have heard from Door Dashers that people order full-scale meals from fast food restaurants at 8, 9, 10 o'clock at night, and eating that late and eating that type of food is not in their best interest. So as a healthcare practitioner, when you learn more about your patient during the annual physical and many visits, do you take those things under consideration when we're talking about the issue of culture of individual patients or the culture of the community that they're in?
Yeah, I do. So for episodic visits, if it's someone, I just recently had a patient with abnormally high blood sugars. It was almost impossible to get it down without getting her connected to a continuous glucose monitor. So I'm constantly monitoring her blood sugar from here. Talking to her about, she's in an assisted living, and talking to her about educating her on the importance of when you guys go on your outings. I know you're going to the 99-cent store, and I know there's a lot of little goodies there, but you can't indulge. You're gonna get sick. So just and then telling her why, telling her the process, how the sugar doesn't break down in her system like a regular person, and how a lot of diabetics, I'm not gonna say most, but a lot of diabetics, they lose their eyesight. So I give them examples like that. You've lived your whole life seeing. Could you imagine yourself living the last part of your life blind? So if you can't, then you can't indulge like the normal person anymore. You lost that privilege when you develop diabetes. So I do those educations. The physical is actually for just really getting into those determinants, those social determinants. Do you have transportation to and from the doctor? You know, are you getting your medication? Is it too expensive? All of those things. That's what the annual physical is for. That's what the wellness exam is for.
Oh, yes, ma'am. And I know that chronic diseases are really the leading cause of death and disability in this country. And part of that, I'm quite sure that we saw a demonstration of how chronic disease can contribute to so many, could contribute to death during COVID. So I know that now I'm asking the people that I counsel, what did you learn from COVID?
Are you asking me that?
No, I'm asking them. I was just pausing.
Yeah.
I asked them that because if you were paying attention, you would have heard in the news practically every single day for 2 years, almost 3, that the people that were dying had chronic illnesses like diabetes and high blood pressure, and those types of illnesses weaken your immune system if you're not eating the right food at the right time. And by right time, it means don't eat all day. Your body cannot take eating all day. In fact, the Honorable Elijah Muhammad teaches us to eat 1 meal a day. You're not going to starve. And if you're eating fresh fruits and vegetables and eating the best of food, you will be in a better health state than you do eating out. And just because it's convenient, it's less taxing on you to stay at home and cook your own food as opposed to ending up in a hospital because of an illness that you basically, not trying to be harsh, brought on yourself.
Right.
Because it's not like someone has not tried to tell you. Your doctors tell you all the time to don't eat this, to exercise more, to do this and to do that. And it's really, really sad. For me, it's really, really sad. And the leading drivers of the $4.1 trillion that is spent annually on healthcare expenditures in the United States is going towards treating people with chronic illnesses. And you talked about CMS and the Centers for Medicare and Medicaid. You want to share with our listening audience exactly how that factors into what it is that the treatments that they receive, not the treatment from the providers, but the services. I'll put it that way.
In terms of for treating chronic illnesses?
Yes. And I'm saying that because the Centers for Medicare and Medicaid, as of January 1st of 2022, their final ruling basically was to kind of take a lot of the financial responsibility off of themselves and contract it out to Humana and Aetna and Kaiser and other insurers, because they're no longer providing certain services as much as they used to. They're not paying for them as much as they used to.
Well, they're trying not to.
Huh?
They're trying not to, but
yeah,
you really can't do that when you have a huge population of sick people.
Well, let me put it this way. That's why they're subcontracting.
That's why.
And that's what's in their final ruling. And I had to sit there and read that whole thing. And I had to read it like 5 times before I fully understood it. But those is like, for example, according to healthcare insurers, and CMS, Centers for Medicare and Medicaid, for any medical condition that a person is hospitalized for. Depending upon what their diagnosis and their prognosis, they can only stay in a hospital for X number of days for this condition, especially if they are getting better. And if they need further care, but not necessarily that hospital room or that bed in that hospital, they may have them go to what they call a skilled nursing facility for just a couple of days. And then they're going to go home. They may be contracted out to a home health agency. And that's where it gets really tricky, because home health agencies don't get paid the same, even though they have a great deal of responsibility, meaning that in the event that that patient, within that 60 to 90-day period of time that they're assigned to that home health agency, if they have another hospital readmission, then that brings trouble on the home health agency, because somehow or another somebody's going to point the finger at that home health agency, and that may not necessarily be their fault. And I'm saying that because that's something that I have observed over the years. And that's what my doctoral study was on: CMS, home health care, and health literacy. And it gets very complicated and get really ugly. They have 432 different categories. And the home health agency has to sort through all of those categories. They call them group drivers for care, so to speak, for lack of a better term. And they have to make sure that for example, if Anissa has been diagnosed with diabetes and high blood pressure 7 to 10 years ago, and she has had several hospital readmissions since the day of her diagnosis, and this last time she's going to go to a home health agency or get services from a home health agency, they're going to scale back according to this final ruling. I didn't write it. According to that final ruling, they're going to scale back on the type of care that I can get in or from that home health agency, and even after I'm discharged to go home. And even though that you're saying that they're trying to, yes, they're trying to, but what I'm saying is the bottom line is that they're easing their way out. It's not that they're going to not give people the health care that their quote unquote, the social policies dictate that they provide for the poor. But if you look at it from their perspective, it's like, okay, we have X amount of dollars, and we have 10 to 15% of the entire population that's using up the bulk of the budget that we have. So we have to do something, and it's got to be done quickly, efficiently, and it has to be something that can actually work in order for them to not have to spend so much money on certain segments of the population who are not taking responsibility for their own health outcomes. So it's like a darn if I do and darn if I don't situation. So, looking at those types of things, and that's why I'm very adamant and passionate about coming up with the best method to get through to patients or just the community, to get them to understand, as my mom used to say, take advantage of opportunities that are in front of you today, because tomorrow they may not be there.
Right.
Does that make sense?
Yes, that makes perfect sense. That's what I feel about the annual wellness exams. That's what I feel about the physical exams. Like I said, only 17% of the population was getting their actual wellness exam. So you're not even going to the doctor to get a thorough check. What's wrong with you? You go to the doctor when you're down, when you're already sick, and and that's not how that's supposed to work. That's not how that system is set up. So a lot of times we see people, like you said, they go to a hospital for a situation, they stay a couple of days, get discharged to a skilled nursing facility. From the skilled nursing facility, they get discharged home with home health. They're not getting any better. If you notice, they talk to the family about hospice, because if you're not going to try to get yourself any better, the system is not going to continue to pay for it. The next step they feel is the grave. So they're willing to assist you in getting to the grave by having, the nurses talk to your family about hospice, about going on palliative care, where we're not providing any preventative services. The only thing we're going to do right now is help you die with dignity and respect.
Ooh, that shit sends shivers down my spine, because it should to basically everyone that's listening, because know that chronic illnesses, the majority of them are preventable. Miss McLeod, we see your hand. You have a question for us, ma'am?
You're on mute.
You're on mute, sweetie.
Thank you, ladies. The information has been overwhelming and sort of like mind-boggling. And it's like, oh my God. But in any event, here's my question. I routinely take once a year an annual exam because my insurance allows me to do that. I'm not aware that an annual wellness exam is a requirement. I mean, I didn't know there was anything called an annual wellness exam. I thought the annual exam was in fact also the annual wellness exam, but clearly it's not. And so is it the case that some insurance coverages does not distinguish those two? Because I'm not aware that I actually should or entitled to an annual wellness exam.
Don't feel alone. I get that all the time. I was out today and I got a patient that said, they had promised someone to come to her house at least 2 times before. And this time she didn't think anyone was coming. So when I got there for her 12 o'clock appointment, she was gone shopping. And I'm like, hello, I'm at your home. And her daughter had to run back. And as I'm talking to them, educating them on the annual wellness exam and the importance of it, they said the same thing. I thought the physical and the annual wellness visit was the exact same thing. It's not. I consistently promote annual wellness exam because the annual wellness exam gives a different approach. Now, to answer your question, the annual wellness exam is a Medicare-driven product. Medicare is the big guy. Like Anissa just said, Medicare has partnered with these different insurance companies, the United Health, the Humana, the Scan, the Aetna, all of those. But Medicare gives the rules. So the annual wellness exam is a Medicare-driven product. All of them are supposed to offer it to you guys, but it's, again, there's so many people, they just can't get to everybody. And that annual wellness exam can only be done by a nurse practitioner, a physician assistant, or a doctor. So there's just not enough of us to get to everyone, so they don't promote it like they should. But I promote it. Because like Anissa just said, there's too many chronic diseases, and our healthcare system is not going to get any better because people are getting sicker and sicker and sicker, and no one's really becoming health literate. They're not really even trying. I mean, people are trying, but I just see a lot of people that really don't know. And because they don't know, and for whatever reason, they're adults, or maybe they were made to feel, stupid when they were kids, or whatever reason, they won't ask the questions. They won't even ask me the questions. And I'm the type, like, ask me anything. Let me be your dictionary. Like, I've been in this for 25 plus years. I know a lot. I've seen a lot. I've worked with a lot. Use me, and people still don't. And I think it's just because of those other things going on. But the annual wellness exam should be offered by all insurances. all insurances, including yours. So it's good. They'll get to you eventually, but if you mention it to your doctor, he's going to say, oh yeah, you want one. And sometimes the doctors rush through it because it's very intense. It takes about an hour, but it's better than not having it at all. And it's important to have your same physician, have your primary care provider that knows you and you know them. It has to be a relationship, because a relationship is going to cause him or her to provide the best care for you because they know you, and that's what you want. That's what we all need. I hope I answered your question.
Yes, you did. Thank you. Thanks very much.
So Shemika, can you explain again the difference between the annual physical and the annual wellness check?
Okay, the annual physical is to check you out to see if anything is going on with you, anything changed from last year to this year, yada, yada, yada. They do your vital signs, they get some blood work, and they tell you you need to get a mammogram or you need to get a pap smear or da-da-da, and then they send you on your way. The annual wellness exam, we're searching for hidden diagnoses, stuff that has not been diagnosed, stuff that you probably don't even know you have. So it's more specific. We're searching for diagnosis that has not been treated, has not been identified, so we can identify it, get on it. Anything you catch in its infancy, it's easier to kill. It's easier to get rid of it. Once it starts growing and all of that, now you got to go through all these treatment measures and all of that. So the annual wellness exam, it's set up to catch those things before they catch issues, before they turn into real problems.
Okay, yes, ma'am. I know that Dexter says that it really helps to be prepared before your physical. Do you have a question?
Yes, I do. Can you hear me? I really think the wellness exam to me sounds more important than the physical, because there's more in-depth talking. There's more of a dialogue going on with the physician and the patient. I think that could be some grounds where if they stay with that provider, that a rapport can be developed, because that's the only way I have dealt with my providers, is to develop a rapport with them and to come in prepared. Okay. And to come in prepared, because like I probably had my labs done beforehand. And so I have my ammunition coming in and talking to them. But and I've never had a wellness exam. So this is something, is it a certain age related?
So it depends. For United, they've just been offering it to all of their patients. If you're an adult over 40, they want all their patients over 40 to have an annual wellness exam, because look how beneficial it is. It's super beneficial. And I'm not going to say, Chef, that it's more important than the physical. I'm going to say it's as important as the physical. You need both of them. Right? But the annual wellness exam, like you said, it does give a better dialogue between you and your provider. If you're doing it with a nurse practitioner that's outside of your provider's office, all of this information is extracted from you. You sit down and you have a real conversation, and then we check for different diagnoses. We check to see if you have neuropathy. We check to see if you have any type of vascular disease. We check to make sure all your pulses, especially your peripheral pulses, meaning the pulses on your feet, are effective. We can feel them. Your heart is pumping effectively. You're not in, low risk heart disease, heart failure. We check for that. We check for all of that, all while we're talking and getting to know you. And all of that information is given to your doctor, so he has a better idea of exactly who he's working with. Any referrals that you need, have you had your mammogram? Have you had your DEXA scan? Have we looked at your bones to see if you have osteoporosis? No, I'm not asking you, Chef. I'm just saying in general.
I understand.
Right.
I
Have
understand,
you had
yes.
your DEXA scan? You know, are you a vaccine person? Did you get your vaccinations? If not, why? Let us know so we can write down that you refuse them and the reason why you refuse them. So you're not constantly asked, do you want this flu shot? Do you want this shot? Do you want, it's documented that you don't take vaccines because of XYZ, your belief or whatever. Everything is put there. You're having a conversation. It's a 1 hour conversation. The nurse practitioner or the physician assistant is listening to you intently. They're asking you open-ended questions because we're trying to extract out of you all the information we need to put this puzzle called Chef Cheryl together. And if there's anything, we ask about family history, because like I said, if your mom, dad, sister, brother have a history of obesity, diabetes, high blood pressure, hyperlipidemia, neuropathy, any of those things, chances are as you grow older, you're going to get it too. So we get on top of that to make sure that you understand that, number one. And then number two, what's your diet like? What's your exercise routine like? All of those, do you drink water? All of those things to just get you on a journey to health. So we're not looking down the road 10 years from now and you're all swole up because you're in heart failure. Nobody told you you were at risk for heart failure or what to do to, you know, prevent it. Annual wellness exam is kind of like if a person is running into a wall, then we come there and say, no, danger ahead, and it helps you turn and get on the road to safety. That's what it's about.
That's awesome. That's awesome. That's
It
some,
is.
that's awesome. It's so emphatic. I love
Great.
it.
I have a question for you, Shemika. So during the annual wellness checks, or let me back that up, during your annual wellness checks with your patients, do you talk to them or have conversations with them about their habits? Meaning that more often than not, the patient, especially if you speak to them in layman's terms, they hear you, they understand what it is that you're saying, but what they're not telling you is that, girl, I hear you, but when I leave here, I'm going to give me a Big Mac, okay? You know, and that supersize me order of fries and different things like that. Do you have conversations with them about their, for lack of a better term, their bad habits or their triggers that may, because especially with women, we have a tendency to overeat or eat the wrong things when we're stressed, when we're angry, when we're having a bad day, and it becomes a habit to where we make excuses to do that. Oh, girl, the sun is out. I think I'm going to go get me, I'm going to do this, that, and the other, because it has become a habit. And we don't understand that the majority of the foods on the market now is not even food. They're food products, and they're loaded with chemicals, and the cells in our bodies become addicted to those chemicals. And and there are also health elements that may trigger cravings. So I wanted to know, as a practitioner and owner of True Care, do you address these needs when you talk to your patients during the annual physical or the wellness checks to find out what their mental health is like? Because depression can cause you to overeat or undereat, and just to find out where they are in the mind and in their behavioral patterns.
It's part of the exam. It's a whole questionnaire. It's a whole section, 10 questions. A part of the exam, I'm getting into your mental health. I need to know. And before we even get there, before I even get started, I take the first 3 minutes and I explain to the patient what this is and what's it for, how it's going to help you. And I also let them know that, a lot of our issues are not being addressed by the doctor because they don't know how to treat you. They don't know you as a person. So that's what I'm going to do right now. I need to get to know you. So I need you to be as transparent with me as possible. No judgment, I promise you. And we get to going, and the more comfortable, they get comfortable with me quickly. I don't know why. Sometimes they get so comfortable, I could barely get out of there within an hour because I just started talking and talking and talking. And I'm like, okay, I got enough information, but they be wanting to give me their whole life. And I think it's because I started off with that first piece, just letting them know, I need you to be transparent with me. And this is just for me to help you. I'm going to take all this information. I'm going to give it to your doctor so we can appropriately treat you. If there's anything going on in your body that has not been identified, we're going to identify and get you on the road to health. And once I give them my little spiel, my little speech, we go at it. And they tell me what I haven't had, honestly, and I'm not even bragging, I haven't had a patient that was resistant to tell me, you know, I want to eat, girl. I want to go get me a Big Mac, and she like 350 pounds. And I'm like, yeah, that's only because it's habitual. You're thinking about it. Your mind wants it. Every year, I want a strawberry shortcake, and I want for my birthday, and I want to eat it all, but that's not practical. That's just going to cause me to get diabetes and all these bad outcomes. So you got to think of it like that. How practical is it for me? How much more is it going to contribute to my health or take away from my health? So we get into it. We get into some good conversations, and I do a lot of educating. We do True Care, we do chronic care management, but we have a focus on obesity management. And because obesity is a chronic disease, and in obesity management, when I come across a patient that have a BMI of 30 or more, then I start talking, letting them know that, you know, our foods are hyper processed, and you got to be very careful with what you're putting in your mouth. And it is out of habit, and it takes time to break those habits. It's not going to break right away, but with support and structure, you could break it. And yeah, so we get into some good conversations, health literacy. I break things down in layman terms to make sure they fully understand what I'm saying. If there's any questions, I answer the questions to the best of my ability. If I can't answer the question, I tell them I'm going to get back to you with that. And I do. I get their email address or their number, and I call them back and let them know I found, and this is what's going on, and know, which that's one of my passions anyway, gathering information, researching information, and then giving it to the public. Like, I absolutely love doing that. That's why I love social media. But yeah, we do.
Yes, ma'am. So, Sister Lorraine, I recognize your hand, but I want to ask Shemika a question. Those 10 questions that you mentioned, that you asked them with regard, is that the PHQ 9? Okay, so I do like this. I roll my eyes up like this when I see PHQ 9 sometimes, and that's sometimes because it doesn't always address situational things. And that, you know, and that's why it's like I have a problem with it. And I've also seen with working with patients that I've had on my caseload, if you could just be in the room with them while they answer those questions, and you pay attention to their body language, you can kind of tell when they're not trying to answer that question. It's like, for example, sometimes the PHQ will ask you, and for those of you who are listening that don't know what that is, it's just some acronyms that stand for psychological health questionnaire. And they may ask you, have you been depressed in the last 2 weeks? I might answer, yes, I have. And I could answer yes to a few more of those questions, but the person that's quote unquote assessing it and adding up that score, it may seem to the provider that maybe I need to, in LA County, when you work for them, they will have you route that person to a behavioral health specialist, or actually DMH. And I think that before that provider does that, then what would be a good idea would be for them to ask you, okay, so what have you been depressed about?
That's what I was about to say. It just depends on who's doing the screening, because if you're just going to ask the questions and not get in depth, then yeah, they're going to say yes, no, things like that. But you had like the anxiety question. Have you had anxiety over the last 3 weeks? Most people are going to say, well, No, not really. You go into it. Have your heart start racing and your thoughts start racing? Have you had any thoughts of suicide, homicide? You don't feel like living? Like, have anything happened in your life to make you feel like that episodes, or is this something that's ongoing? It's the person that's asking the questions. And if you don't really know the PHQ-9, you are just going to ask them just blanket questions. They're going to be like, yes, no, yes.
The majority,
no.
since the majority of the time, if it's done in a PCMH, which is another set of acronyms that mean primary care medical home, you're being asked those questions by a medical assistant, somebody that came in and took your vitals, and they're at a computer and they're asking you, have you felt depressed? Click. Have you done click, click, click? And then they just add that I think it's programmed to add up the score. They send it to the doctor. But what I meant by situational, maybe over the last 2 weeks, I've experienced 2 deaths in the family.
Exactly.
Or something of that nature. And when and maybe that's contributing to this spike in my blood glucose level, because stress raises your cortisol levels, which raises your glucose levels. And they're not, they act as if these things don't coincide with one another, and they do. And they look at it from a superficial level. So if I had my choice to change something about the healthcare system, it would be the policies that undergird what they do and why they do it. I mean, for example, A1C's an A1C test result means different things at a different facility. I would change, why not just make it uniform so you won't confuse the patient? For example, say I went to the emergency room at Acme Hospital and my A1C was 6.5 when they took it. I went back 30 days later and they told me that 6.5, oh, Miss Muhammad, you're doing good. That's that's good. And you walk out of there thinking that you really have done something, right? But when you go back to your primary care provider and your A1C is like 6.0, and then they're telling you that your blood sugar, your A1C is too high, and now you're confused. I've actually experienced that, and I've actually seen it where it's good over here. So 6.0 is good here, here, and here. But in other places, they tell you that your A1C is too high. So I would set a standard for a standard testing that they do for blood glucose levels and different, what is a healthy blood pressure and different things like that, because it's very confusing to the patient. If one doctor tells them that their 6.5 is good and somebody else is telling them 6.5 is bad or 6.0, you really do need to start taking your medications more, then that would be very confusing to a patient. So I would like to change the standards of different things and have it uniform across the board. And I have something else I want to ask. Hey, Sister Maria Isabel, we see you. Sister Lorraine, you have a question? You're on mute.
Yes, thank you. This question is for Anissa. Now, Anissa, both you and Shemika earlier in the presentation shared some startling statistics on health literacy of patients, right?
Yes,
and
ma'am.
You also shared your story, a personal story where you have a lot of knowledge, you were in the field, and you were in a situation where, as you were interacting with your doctor, she wasn't paying any attention to you. And had it not been for the fact that you knew your condition medically and could express it in a way that she looked up and thought, wow, I'm dealing with somebody who is knowledgeable, who knows what's going on. And so she paid a lot of attention to you, and your visit ended up being something that was positive.
Yes.
My question is, that doesn't happen to a lot of people. it just doesn't. And I was thinking as you were talking about the situation with my mom, who she's deceased, she's now deceased, but I remember her just being so nervous about going in to see a doctor and not having the ability to maybe express her condition and her ailment in that way, and maybe the doctor not having a lot of patience, because now I understand they only have 20 minutes to kind of do their thing. So my question to you is, what do you think of advocacy, or what do I mean by that? Having a person who may be a family member or a trusted friend to go in to see with that patient to the doctor's office or during the doctor's visit, would that be something that would be useful or should be encouraged?
Absolutely. And I say that for two reasons. I know that Los Angeles County Department of Health Services had employed community health workers, and I was one of them. And what we were specifically trained on motivational interviewing, teach backs, extracting information from patients. And we also were taught about body systems, anatomy, a little bit about physiology and anatomy, and what our specific particular task was to help the doctors to be able to help the patients better. This is the medication the patient is on. This is what some of the side effects are. Be on the lookout for the side effects. So it's that sort of thing. When it comes, and we were very good at our jobs. However, they phased the community health worker out of the primary care home, and we came under the auspices of social services. So that kind of took that task off the board. Mm-hmm. What I would suggest for anyone that needs an advocate, that advocate really needs to be trained to hear, because we would have family members come to doctor's visits with their family member, or, just to be a support. But if you don't know what's going on with that particular family member, that family member may not be able to benefit that patient. I'm gonna give you an example. I had a patient whose cancer had returned, and his behavior got very, very erratic. And I know that his family member was supposed to help him manage his diabetes by making sure that he took his insulin, et cetera, et cetera. But I noticed that when his brother came into the picture, that he had more episodes of either hyperglycemia or hypoglycemia. And I tried to find out what was going on. And when I did a home visit, I found out that the family member could not read. So he did not know the insulin had to be refrigerated. He couldn't read the label. Nobody taught him how to pull the exact amount in the needle in order to give his brother that injection, because his brother wouldn't do it himself. So if you're going to have that family member, or like in the instances of doing in-home support services, if they're going to have a family member or another loved one accompany them to their visits, that's wonderful, because 2 eyes and two ears, or 4 ears, are better than just the 2. But they have to be able to write down exactly what the doctor says, to pass that information on to Shemika, for example, or to somebody else that's going to be in their care, so that they'll know what it is that they're supposed to do. Because if they don't know how to pull insulin out of a vial into a syringe in the correct way, it can still end up the same. Does that make sense? I recommend that they have someone be there to advocate, but they have to know what they're advocating for. Shemika, you have your hand up, beloved.
Yeah, that's one of the responsibilities, Lorraine, of a care manager. That's one of the responsibilities that a care manager hold in chronic care management and the whole chronic care management spectrum. So that's a service that's also offered by Medicare. That's what we do, chronic care management. And I have been to several doctor's appointments. As a matter of fact, I have one tomorrow with a patient that's going to see the cardiologist for the first time. And, you know, of course, he was like, I don't know what they're going to be talking about. So that's one of my responsibilities, or I could have sent my RN with him, but she's on a different assignment for tomorrow. So I'm going to go to his cardiologist with him and just sit in and interpret exactly what's being said and what he needs to know. Not only that, when a care manager or when someone accompany you to your doctor's appointment that's in the healthcare arena, you get better results because the doctor knows that this person knows what they're saying and they know that they have to do their job. So that's one of the responsibilities of a care manager. Again, chronic care management is offered by Medicare. It's a Medicare-driven service. You have to be 65 and older and have at least 2 chronic conditions. That could be high blood pressure, diabetes, high cholesterol, you know, high blood pressure, heart disease, arteriovascular disease. You have to have 2 chronic conditions, and then Medicare will allow you to have a care manager, be a part of a chronic care management practice and have your very own care manager who helps you navigate the healthcare system, which include going to your doctor's appointments, even by phone. Like I have been on the phone with the patient before at her doctor's appointment. So when the doctor comes in or when the PA comes in, she let them know my MP is on the phone. I want her to listen in. I give her permission to listen in, and they're Johnny on the spot with them. But of course they're gonna be, because you got somebody, you know, in their lane, another provider listening. So they're going to do exactly what they're supposed to do when they're being watched. That's just about anybody. So it's a good idea to have somebody to go with you. But like Anissa said, make sure it's somebody that knows what they're advocating for, not just anybody, because they'll just be as blind as the patient.
I'm glad that that she asked that question, Lorraine, because I didn't know. I mean, I'm glad that you shared with us, Shemika, because I didn't know that Medicare actually provided that, but I think it's a shame that somebody has to be 65 or older in order to have a chronic care manager to, you know, in that respect, because if they provided that service, or Medicaid, the Medicaid part of CMS provided that type of service to people that were younger, perhaps they wouldn't need one by the time they're 65.
Exactly.
So we have 4 minutes left. Chef Cheryl, are you still with us, ma'am?
Oh yes, I'm just taking in all this information. It's just very wonderful. And when you spoke of that, and I said the wellness check, I said, well, you said Medicare, because I don't have Medicare yet. I'm not 65, you know. And when I do turn 65, I only have one chronic care thing. So I wouldn't qualify.
You will qualify for the wellness exam. So everyone qualifies for the wellness exam. And if you have United Health Care as your
I have Kaiser. Kaiser.
So no, Kaiser, you got to be 65 and older. And they have a choice. Like they could do 65 and older, or they can choose to do all of their patients over 40, because over 40, we know certain processes start slowing down. Anyway, United Health is one that do over 40, all the residents, and then everybody else follows the Medicare rule and do 65 and older. Now for a chronic care manager, you have to be 65 and older because that's a Medicare product. So what I do is I have Kaiser patients, and when they don't understand something, then they'll call me and I'll do a chronic care visit with them, and I'll just charge them the Medicare rate, what Medicare pays me for, but it's out of pocket for them because they're actually a Kaiser patient. And here's the thing, if you're not understanding what's going on, I suggest that you do find a nurse practitioner, a physician assistant, someone that can accompany you, someone that can break these things down for you, because it's only going to benefit you and your health and your future. So we do it for just general people, but Medicare does it, chronic care management for people 65 and older, annual wellness visit for people 65 and older, unless you have United Health. United Health does 40 years old and older for annual wellness visits. United Health is trying to be up on it because the healthcare cost is just extremely high.
Now, let me ask this question. You're talking about these
we got 1
providers,
minute left.
United
1
Health. Good, we have until 8 o'clock, don't we?
No, 7:30, but we can take it because I need Shemika to talk about True Care and her race.
Right. Well, all of you, both of you. So United Healthcare, and there was another provider that you mentioned. Would it be the demographic of the people that you're seeing that is more risk, that is at a higher risk than some other people? Does that make sense to you? Does that make sense, the question I'm asking?
It does. So
Okay.
We know that people in lower income communities are going to be at significantly higher risk for different chronic diseases.
Right.
If you are not, if you're moderate or higher income, then 9 times out of 10, you're going to your doctor's appointments. You don't have those social determinants of health. Social determinants of health are those things that affect you, that keep you from keeping your doctor's appointments, getting your medication, keep you from being well. Like you don't have transportation to get to the doctor, so you're not going to your doctor's appointment. You don't have enough money to buy a certain medication, so you just don't get it. Those are called social determinants of health, right? The wellness exam look at all of those things. And if you are lower income, you're going to have more of those issues. You're going to have more social determinants that are going to keep you from getting well. If you have a car, you can get back and forth to your doctor's appointment. You know, if you're moderate income, you could probably afford the medication. Your lights are probably not off. You probably have access to clean drinking water. You probably have access to nice grocery stores like Winco's who have good foods and stuff. But if you're in a lower income community, you're going to like Superior or places that don't have fresh meat and things of that sort.
Right.
So
now,
yeah.
I guess the question I was asking was that the type of carriers that, like you said, the United Health plan, is that like sort of like income based? And that's how they say, okay, but look, United Healthcare has this cross section of people. So we need to be a little bit more hands-on with them because just all those factors that you said.
The majority of the number one, the majority of HMOs, which is what Kaiser has a form of HMO, but they also do PPO.
I see.
And,
okay.
You know, and I'm not sure about United Healthcare, but the majority of the like Blue Cross, Anthem and stuff like places like that, they have HMO, but they also have PPO.
And the HMOs are the ones that
are the ones that's in our communities. And I know that again, and there are other social determinants of health, and that includes communities that are in food deserts. Living in a food desert is a social determinant of health, as Sister Shemika mentioned. Living in a community where there's a lot of gang violence, that's also a social determinant of health. Other social determinants of health are not social necessarily, but they can be environmental. So if you're living in a household where there's domestic violence going on, and it sends you into a state of depression, mental not so solid mental health status is also a social determinant of health, because you may overeat or undereat. If you don't have adequate transportation, you can have a car full of gas and you can drive and you can see well, but if you got to duck bullets to go outside to get in that car, that's a problem. And all of those different things also contribute to a poor state of health. And just as far as that goes, I know that a lot of, or should I say, some healthcare systems will throw about the term having access to care. And sometimes that translates into, well, I live right here. There's a Food for Less right here. There's a 99-cent store right here. There's a Superior here. They all sell food. So you do have access to food or fresh food, but they don't know the quality of that food in those markets that Shemika mentioned, because they don't shop there. And just because it's a store and they sell broccoli does not mean that that's the best quality of broccoli that is there for human consumption. So it depends on a person's frame of reference as to what they mean by having access to care. You may live in a rural area where buses come once every 2 or 3 hours. But according to those that make up the rules and define what access to care is, you have transportation. Oh, the buses run, they have a bus that come out there and one that goes back, that to them, that's proper access to care. But to us, it's not. I can't afford Lyft. I can't afford Uber. What if my granddaughter had to go to the emergency room last night and my daughter was the one that was going to take me to the doctor? So I don't always have transportation, and the one thing I can say about LA County is that they did get their patients taxi vouchers. They did provide, they do have shuttle buses that will get them to and from their doctor's appointments. And that much I can definitely say. And then some of the healthcare plans even would pay for phones so that they can be in contact with their doctor. They would even pay for their transportation via Lyft or Uber. And I think that was a good thing, because when they started providing that service through the funding that they were getting, it did improve that patient's ability to make it to and from their doctor. But there are, it's a lot of different social determinants to diseases, and overabundance of fast food restaurants are considered a social determinant of disease, because it's in society, it's right there on the corner, but it's very, very difficult to the process of change in a person's mind to get them to understand that eating at fast food restaurants or eating out 3 or 4 days out of 7 is not healthy for you. Or even eating processed meat and cheese is not healthy for you. And that's the hardest part about trying to help someone with chronic diseases. But if you can speak their language and really get inside their head, they may not comply at that moment or even in that week or that month, but it's something that Shemika said to them that's going to come back and slap them in their face, and they're going to say, ooh, now I get it. Now I understand. And unfortunately, it may take another hospital admission, but that's unfortunate, but at least they will, at that particular point in time, when you get this close to passing away, then maybe they will consider changing it, because that's really a chemical addiction, not illicit drugs, but the chemicals and food products are highly addictive. Sugar is highly addictive, but they don't have a Sugar Anonymous group like they have Alcohol Anonymous and other things like that. I wish they did.
Let me back up for a minute here, because you were almost at the end of them saying, they're in their second visit to the hospital. At what point are you asking the patient, what are you eating? How are you getting food to the table? Are there questions? Is that type of questioning in these wellness checks, in these physicals? Is it a standard question that's asked?
It's in the wellness exam. In terms of the physical exam, remember the physical it's just something different. They're examining your body, they're looking inside your body, and they're referring you for screenings like mammogram and stuff like that, right? That's a physical exam. Let me look at your eyes, let me look at your throat, let me listen to your heart, let me get some labs drawn, let me get is it time for your pap smear? Is it time for your mammogram? That's a physical exam. Wellness exam. Yeah. What are you eating? How many times a day are you eating? What does those meals consist of? Are you exercising? Are you getting at least 150 minutes of exercise a week in any form? 10 minutes here, 20 minutes there, 30 minutes there. Are you getting 150? Do you have any issues that would prevent you from getting the type of foods that you are supposed to eat. Are you eating at least 6 fruits and vegetables a day? Tell me that. Are you, not you per se, but are you eating at least minimum 6 to 10 fruits and vegetables per day? Do you know out of 500 patients, about 90 told me no? The number that I got across the board, the majority was 2 fruits and vegetable a day. And I say fruit and vegetable combined. I don't say fruit and vegetable, 6 fruit and 6 vegetable. I say fruit and vegetable combined. Are you getting a minimum of 6? No, I had this one guy tell me I don't like vegetable. And I'm like, you're like 66 years old. What do you mean you don't like vegetable? It's an acquired taste. He's like, I don't eat vegetable. I don't eat none. So those things are being asked during the wellness exam. It's getting down to those social determinants of health, the physical, all of those things I told you for the physical, and depression, social determinants of health. Do you have transportation? All of those things. That's what the wellness exam is for. That's why it's so important. I'm telling you guys, it's important.
That's awesome. Thank you so much. Thank you.
Thank you, Shemika.
You're welcome.
Thank you. You have a wealth of information. So what you're saying is that you're somebody that is available to go to medical appointments with people?
Yeah, I do.
Mm.
I either do physically. Tomorrow I'm doing a physical appointment. The reason I'm doing physical is because it's his first time at the cardiologist appointment and I want him to see me in my face with him. And then I do over the phone. I'll be on the phone, and the patient, when the doctor or the PA or the NP come in, I instruct my patient to let them know I have my nurse practitioner on the phone with me. I give her permission to sit in on this doctor's appointment to interpret what's going on. I tell them exactly what to say. And the doctor's like, okay, sometimes they get a little intimidated, but hey, it's your health, it's your body.
Okay, so anybody that's 65 or over qualifies to have your services then?
Qualified to have, so for chronic care management, you have to have 2 or more chronic diseases. For wellness exam, anybody 65 or older, anybody can have it. And if you have United Health 40 and over, you should tell them, I want a wellness exam. Send me out a nurse practitioner, or when can I come in to get my wellness exam? I want my wellness exam. It's not a physical.
Okay, I have Anthem Blue Cross.
Oh yeah.
Okay, so you qualify?
Yes, you definitely do.
Okay, all right.
Definitely.
Okay, but I need to talk to you about how we can get together so you can talk to doctors for other people, not me, but for other people that I know.
Okay.
Thank you.
Absolutely.
In other words, she's asking for a friend, okay?
I'm here for you.
Well, my doctor doesn't know what to do with me because he can't figure out what medicines they can give me because I don't take anything.
But you chose the holistic route, right? You chose eating well and exercising, drinking good water, right?
Yeah, so there's nothing that they can find that they can give me medication for.
Excellent.
But that's a good thing.
And that's a good thing. That's a good thing.
Excellent.
I had the same response from my healthcare provider. There was nothing she could talk to me about, my labs, my everything, but it was a physical. So now I want to go get a wellness check just so I can, have that backup. Now, again, like I said, I'm not 65, but I can go to Kaiser and say I want a wellness check.
You got it. For Kaiser does it at 65 and older, chef.
Okay.
Kaiser follows the Medicare guideline.
Okay. So if I just want to go in and talk to my provider, it's just going to be an appointment.
It'll be
and I'm going to say,
yeah, go ahead. I'm sorry.
It'll just be an appointment to talk about my wellness, correct?
When you
But
go
with-
to your physical, you can kind of turn it into a wellness. I could teach you how to turn it into a wellness exam by
Understood.
having a list of things that you need to discuss with them, and they have to
Understood.
discuss it with you. So that's how you get it if you want it earlier. It's still
Understood.
not going to be coined wellness exam because technically for Kaiser you have to be 65, for HealthNet you have to be 65, for all the others you have to be 65, for United you could be 40 or over, but you could still get the information that you need from them by going in prepared with a list in your hand.
Understood. Understood.
Yeah.
Okay. Understood.
Or you can just ask Shemika to come do her start with an annual wellness check. She come to you. You can get it through True Care.
You can.
Oh, so you work through some, so we can actually have Kaiser or anything else and still work with you?
Yeah, okay, so Kaiser is its own conglomerate. Everything is done internally. So my Kaiser patients, they pay cash. They pay cash just to get whatever they need. Right now, and I'm getting a large amount of Kaiser patients that's asking me to write them letters because they want to get on, Ozempic or Wegovy for weight loss. And I'm doing a lot of that. So I charge them a nominal fee to write them a letter, and I let the doctor know why they need the Ozempic, what their labs are like, all of that, what the studies show, how it's going to save them from becoming diabetic within the next 5 to 10 years, all of those things. And they take it to their doctor, they email it to their doctor in Kaiser, get an appointment, the doctor bring them in, draw some labs, give them the medication that they need. So that's how people on Kaiser use me. I'm credentialed with Anthem Blue Cross. I'm credentialed with United. That's how I know the rules for annual wellness exam. So those people, the practice just run the insurance. I have a practice administrator. She run the insurance. Say, yes, Shemika, she's a go, call you, set your appointment, and I come to you, do what needs to be done, the annual wellness exam. I submit everything to your primary care physician, and I get paid through Anthem, Blue Cross, Blue of California. I have on Blue.
Okay.
Understood. Understood.
That's
Thank
how
you
that
so much.
Did I make it
Now,
clear?
Yeah,
I did?
you
Okay.
did. You did.
Yeah.
Let me just ask you something. Okay, go on, Maria. Go on, Maria.
I was always wondering how I can use you because I know you're such a ethical person, and but I have never really known how I can use your services. Thank you. I appreciate that.
No problem.
Okay, I just wanted to go a little off base for a minute with that Ozempic. What can you tell me about that drug? Because I'm reading about it, and the side effects aren't that great, but people are still using it for this weight loss situation, and it just doesn't seem like a healthy thing.
Okay. So what's your question?
Well, my question is, what do you think about that Ozempic? What are your thoughts about that as a healthcare provider?
So Ozempic is a glucose, which is sugar-like peptide, amino acid, right? Our bodies naturally make it. Our bodies naturally make this GLP-1. That's what they call it, glucose-like peptide, GLP-1. But as you grow older, you gain weight, you become diabetic, all the natural processes go off. So your body's not making as much of that GLP-1 as it used to. You're replacing that hormone, that GLP-1. It mimics, the Ozempic mimics the GLP-1, and you give it to yourself. You replace it by giving it to yourself, and your body acts as if it has made it itself. What it does is it holds the food in your stomach for a longer period of time. The food doesn't just dump into your intestines. So because the food is held in your stomach for a longer period of time, your stomach sends messages to your brain like, hold up, we're full, don't feed us no more. So you're not overeating, which eliminates the appetite, right? That's the first thing. The second thing it does is if your hemoglobin A1C, if you're pre-diabetic, which is 5.7 to 6.4, I know you guys don't know what those numbers mean, I'm just throwing them out there. If that's pre-diabetic, then it brings that hemoglobin A1C down and it gets you out of trouble. Because if you're pre-diabetic, 9 times out of 10, within 5 to 10 years, you're going to be full diabetic, needing medication, whether that's insulin and pills or just insulin. But if you're pre-diabetic, 5.7 to 6.4, within 10 years, many studies have shown you're going to be a full-blown diabetic. Ozempic prevents that from happening. It helps to prevent that from happening. The biggest side effects is GI side effects, your stomach, the nausea, the vomiting, the burping, belching, the gas, and it happens for about a month to 2 months. That's until your system get used to making this GLP-1 again. Once your body gets used to it, then the side effects subside. The other side effect is goiters, thyroid cancer. However, up to 3 months ago, I looked on the FDA website, not one human subject has acquired thyroid cancer. Rats in the lab that they tested the medication on developed thyroid cancer. So they're saying if you have thyroid disease or a family history, remember genetics, a family history of thyroid disease, then you're a different class and you can't have it. You shouldn't put yourself at that risk. Although no human subject have acquired thyroid cancer because those rats did in the lab, then they're saying that it's just not safe for human consumption if you have thyroid disease or a family history of thyroid cancer. Sure, Chef Cheryl, your question was, do I think it's safe? I think it's safe if you don't have thyroid problems, and I think it's safe if you utilize all the tools. What do I mean by tools? You get on a diet, you find a diet that works for you, whether that's the Mediterranean, whether that's the hypertension diet, whether that's the diabetic diet, keto diet, you get on something that you agree with, you start exercising that 150 minutes per week, whether it's 30 minutes a day, 30 minutes 5 days a week, or 10 minutes here, 15 minutes there, 150 minutes a week, and any other tools that your Apple Watch, you see, I always wear my Apple Watch. Those are tools that we use to help us in weight loss. You put together all those tools because your appetite is going to be decreased. The medication is taking care of that part. Now it's your responsibility to utilize everything to get the weight off, change the lifestyle, and become a healthier version of yourself. It takes about 21 days to change a habit. It takes 90 days to change a lifestyle. So take that 90 days and change your lifestyle and get yourself on the road to health. So I 100% think it's, after you've had a workup, I think it's 100% safe.
Thank you. That was more than adequate information.
That was too much.
Sure.
But I appreciate it. Yes, ma'am.
Okay, it is 7:52. Would you close us out, please?
I certainly will, but I'm not going to close you. I'm not going to end this webinar without you ladies giving your contact information and business, because I think that would be the correct thing to do, so they can, when people click on this 2 years from now, they can go, oh my gosh, how can I get in touch with Anissa and Shemika? So ladies, if you would please leave speak of your business and your contact information now before we close.
I cannot, for some reason, get into the chat. Sister,
Yes, you can. It's just right there.
I see where the button is, but I'm not able to see it from my screen. That's what I mean.
But if you can just say it, that's.
Yes, please.
Anissa Muhamed, Sisters for Life Health Equity Group. We are a nonprofit organization, and I do a lot of patient navigation and patient advocacy work. I also am a domestic violence counselor, and I do just a myriad of services up to and including helping patients with their healthcare needs. And I consider myself a health elevation specialist. So I do help patients with managing their chronic illnesses. My email address is sisters, SISTERS, the number 4, life, health equity @gmail.com. Thank you so much. And thank you all. So Shemika, thank you. You were awesome.
Thank
Do
you.
you have
I
a phone
appreciate it.
number?
323-921-5658.
Shamika, please give us your contact information.
So I'm Shemika with True Care Telehealth and House Calls. We are a chronic care management and obesity management practice. We help patients make life-altering transformations, get on the road to health, and understand their health. We interpret basic health information. We're located in Diamond Bar. I have a clinic in Diamond Bar, California. We do telehealth, where we could do an appointment over the phone. And I also do house calls. I come to your home. I have a roll-in clinic, and I take care of the patient in their home. The number is 951-405-0444. And I am info at True Care, TRUC, as in cat, ARETELHEALTH.com, telehealth.com.
Thank you, ladies. Thank you so much. This has been a plethora of information, if I could just say that, and that is putting it lightly. I would like to thank Nurse Shemika and Sister Anissa for this wonderful information. And I'll be stopping this recording in 1 minute, but we will be definitely uploading this to YouTube. So if you ladies can stay on just for 2 seconds after I'm done, we will end this. But thank you so much. This is the LA South Chamber of Commerce, the LA South Hope Foundation. This is the Health and Wellness team who has brought us some wonderful information on patient health and patient dialogue with their physician. We thank you so much for this information, and we look forward to the next time, because this should not be a one-off. It should definitely be something that we continue this conversation. So again, thank you so much.
Yes, thank
You're
you.
welcome. It was an honor and a privilege. Thank you.